one of the major obstacles to the long-term CLL cure is now the Richter syndrome. That is the occurrence of an aggressive lymphoma in a patient with chronic lymphocytic leukemia. So this aggressive lymphoma, the Richter syndrome, has a very, very poor and very dismal prognosis. So the novel agents that have been developed over the past years in CLL first did not efficiently prevent the occurrence of the Richter syndrome, and in addition are not very effective in treating the Richter syndrome. So there is a need for new drugs for such a complication. So genetic can help for the diagnosis and the management of the Richter syndrome. So we are developing, for example, liquid biopsy in assessing the circulating DNA in patients with Richter syndrome, and we've shown that we can detect Richter syndrome lesions in the plasma of patients with Richter syndrome, so that we can be maybe able in the next future to detect earlier the Richter syndrome in the patient with CLL. In addition, one of the major obstacles when we study Richter syndrome is that within the same tissue biopsy, we have both Richter cells and CLL cells. So we have a sort of CLL in Richter contamination, and that is a major change when you want to decipher and really understand what is going on in the Richter cells. So we also are developing phylogenetic reconstruction to be able to track the Richter clone and determine the Richter mutational landscape in a reliable way. Regarding now the new treatment, so there is multiple ongoing trials worldwide for this dramatic complication of CLL. But what we have developed in the setting of the PHILO, so the French CLL group, is checking and using and evaluating the bispecific Blinatumomab antibodies that has been developed for acute lymphoblastic leukemia, and even more recently that has been also evaluated in diffuse large B-cell lymphoma. So we use this approach after a debulking phase, including 2 R-CHOP cycles, and then the patients of our trial received an 8-week course of Blinatumomab, and were evaluated after this 8-week course. And what we observed is that for patients who are not in CR after the debulking phase, we have 18 patients who have completed this 8-week cycle of Blinatumomab, and we have seen that the response rate was 44%, and half of them were in complete remission. So these are preliminary results that suggest that Blinatumomab is an effective approach in patients with Richter syndrome, and the safety profiles was also pretty acceptable.